This talk is going to be just simply an introduction to the subject, and it will just help to clarify the terminology that's used. So hence I entitle it an Introduction to Substance Abuse. The term substance abuse, to start off with, is often used generically to encompass all the use of any type of a substance. And it can also, in DSM-4 nomenclature, it has a specific description. It's describing a typical misuse of a substance. But however, the term substance abuse is not a particularly good word, because it's not the substance which is being abused, it's really the person who's being abused by the substance. Understand? So again, that is the first sort of confusion that we have. Just so as by way of introduction, just to let you know how significant this issue is, $40 billion a year is the cost to the Canadian economy by people who misuse, abuse, or are addicted to substances. And I'm sure you're aware of so many people who come into the hospital emergency rooms or admitted to hospital are under the influence of substances, or they're there because of the chronic use of substances. 40% of psychiatric admissions. So substance use disorders can be broken down into these four classifications. Substance misuse, and you won't find that anywhere in DSM-4. And I'm sure you're all familiar with DSM-4. Anybody not? Yeah. Okay. DSM-4, unfortunately, is not a good text, and I'm very cynical about it because it's published by the American Psychiatric Association. But the American Psychiatric Association is not exactly replete with funds, so it relies on two wealthy industries to actually publish it, and they are the pharmaceutical industry and the insurance industry. And the pharmaceutical industry has a vested interest in it, because if someone can be classified or pigeonholed with having a certain diagnosis, then that is justification for the doctor to be encouraged to prescribe certain medications. And similarly, the insurance industry will not pay benefits to somebody unless they have a psychiatric diagnosis. And so it helps to make it easy for those two industries to make their money. So B, C, and D are found in DSM-4, but not A, because that's my own definition, and I will sort of present that in just a minute. But so here we have substance abuse, and then the substance dependence as defined in DSM-4, and then these substance-induced disorders, and they speak for themselves. And when they talk about other, they're really referring to all the physical complications of substance use, such as the cirrhosis of the liver, which is the commonest. And when I was at medical school, just relatively recently, that's how they thought that the only physical complication of alcohol ingestion was cirrhosis of the liver. And in fact, they try to estimate how prevalent addiction to alcohol is based on the cirrhosis levels. So we know now that there is no part of the body which is immune to the ravages caused by alcohol. As you know, even the cirrhosis is more common in people who drink heavily. Just cut out your drinking, and most of the condition sort of subsides. So let's take a look at this first bracket of substance use disorders. Substance misuse. It's the inappropriate use of any mood-altering substance, and it's often part of formative behavior. So that second part probably rings true with a lot of people. Certainly does with me. For example, if someone was to have one glass of beer, it's not really a problem, but have 2 or 3, come home a little bit late at night, cause a disturbance, then that would be considered substance misuse, because there has been a negative consequence as a result of that substance use. And I always remember the story that I came home after going out to the pub one night. There was a loose floorboard. It was about 3 steps up. And I remember the night I'd been to the pub, would you believe, I managed to step on it. Well, that woke up everybody up in the house. The lights went on. My father came out of the bedroom and he sort of advised me not to come home late at night. Well, that was it. I dealt with it. And so it wasn't repeated. But, you know, if I'd not taken their advice, my parents' advice, and I continued to go out, continue to create a disturbance, that's the first hint that we're slipping from substance misuse into substance abuse. So it's the inappropriate use of any substance, and that could include things like even diamond hydronate. I have one nurse who first came to see me some about 15 years ago, because she was taking over 100 diamond hydrate tablets a day. It had started off with 1 tablet in order to adjust to the shift change, and it just gradually escalated. So she was eventually taking 100 tablets a day, and did so for about 15 years. Has been absent for over 3 years, and all her sort of choreoathetotic movements that she developed as a result have completely subsided, and she's doing extremely well. So if substance misuse continues beyond the formative years, you know, our teenage years, our early 20s, then it is slipping into not so much a behavioral issue, but it's the first hint of it becoming an ingrained pattern of behavior. And that is substance abuse. And that's best defined as the recurrent use of any psychoactive substance despite the negative consequences. And the salient points in that definition are that it's recurrent. It happens time after time. The use of the substance as is inappropriate. Let's go back to the archetypal form of substance abuse, which is alcoholism. If one was to have 1 or 2 drinks in an evening, that's acceptable. But to have 4 or 5 would perhaps be inappropriate, because then your behavior is going to be compromised. Taking a gravel tablet to aid the management of nausea, that's appropriate. However, to take 4 or 5 tablets in order to induce sleep, that's inappropriate. That's the second salient point. And the individual continues to use the substance despite the fact that things go wrong. So, in other words, think of the analogy. You go into the kitchen and the red hot stove is on, and you put your hand on the ringer and you burn your hand. You say, God damn, that hurt. But then next night you go in and you do it again. So you keep on engaging in strange behavior despite the negative consequences. That's the first hint that that behavior is not under control. It's the first hint that substance use is an illness, it's a disorder, form of insanity. Let's take it one step further. What is substance dependence as defined in DSM-4? It is, in essence, substance abuse, which we've just defined, but it has progressed, and it's now associated with loss of control. Now, people don't always understand what loss of control is, but there is a packet of potato crisps which the caption states, bet you can't just have one. Now, if I was to standing here and open that packet of crisps, put them in front of you, and you had one, you'd be at it, and you would not be listening to me. You'd just be more focused on finishing all those crisps till it was empty. Then you'd realign your attention to what's on the screen. That is loss of control. Now, you multiply that probably by a factor of 20, we're talking about alcohol dependence. A factor of 100, cocaine dependence. Loss of control is indeed that. You do not have any control over your behavior. And invariably, substances dependence is associated with inability to abstain. How many times do people wake up in the morning and say, after they've been out drinking, their mouth is like a parrot's cage, got a hatchet in their head, they say, they ache all over, I'm never going to touch that stuff again. But lo and behold, they do. And as you know, alcoholics are the best abstainers. They abstain all the time. They just tend to relapse the following night. But people who are substance dependent are unable to abstain for a prolonged period of time. So here I put up on the board substance misuse, substance abuse as defined really in DSM-4, and substance dependence. But if we then talk about the term substance abuse and using it generically, as I alluded to earlier, you can see that it's a spectrum of varying severity. It starts off with substance misuse, which is not a pathological entity. It then, however, if it's not corrected with education and guidance from peers and parents and teachers, it can blend into substance abuse and then into dependence. And it's more likely to progress down that spectrum contingent on how much genetic material you inherit. So if you, say, come from a family where there are many substance abusers, then it is more likely that you'll become an abuser yourself. If one parent is a substance dependent, then it in actual fact doubles your chances. And if both parents are substance dependent, it quadruples your chances of becoming substance dependent yourself. So the generic term substance abuse is really describing a spectrum of varying severity. So looked at another way, it's substance misuse, which is that irresponsible use. It blends into more moderate abuse, and then it becomes severe abuse, and then ultimately dependence. And it's quite evident that the more the substance is used, the more problems there are likely to be developing, and the greater the risk of the individual becoming dependent. However, once someone progresses through their substance use from misuse into abuse, into the point of being dependent, if they've crossed that Rubicon which separates abuse from dependence, in essence, there's no going back, because this line, as they're progressing from misuse, abuse into dependence, this line is represented by the development of that symptom of loss of control. Once the individual loses control, they can't return to controlled use. So that's why it is impossible for someone who is alcohol dependent to return to controlled drinking. It just doesn't work. If someone ever does manage to assume or resume controlled drinking, it's probable that they were never dependent in the first place. Or they may temporarily be able to exercise control, but there's no guarantee that in the face of stress that they won't manifest symptoms of dependence again. So that's why it's no good to tell someone who is substance dependent to cut back on their substances. They would do it if they could, because they're getting no end of negative consequences. So there's no advantage to a physician saying, well, you just need to cut back and control your drinking. They can't. They just can't do it. So substance dependence now can either be physical or it can be psychological. And if you take a look in DSM-4, there is no mention of the word psychological dependence. That's why, in my opinion, as an addictionist, I feel that DSM-4 is best off in the bin. It's no help at all. But because I work so closely, unfortunately, with insurance companies, I have to use this terminology. Even DSM-5 is not going to talk about the word addiction. It's not going to talk about psychological dependence. It's just going to collapse substance abuse and substance dependence into one spectrum, but which is somewhat of a progression. So you now need to be able to differentiate the two. In DSM-4, however, what it does say is that the individual is exhibiting physiological symptoms of substance dependence. In other words, they manifest tolerance and withdrawal. Tolerance, as you know, is the need to use a substance in order to achieve the same effect. As we drink more and more alcohol over a longer period of time, our metabolism changes. We're able to excrete the alcohol and its metabolites more quickly, and we neuroadaptively adjust in order to be able to conduct ourselves under ever-increasing blood levels of alcohol. So that's your tolerance. Withdrawal is manifested by the symptoms and the behaviors that an individual exhibits when they stop using the substance. So that's tolerance and withdrawal. Now, if someone exhibits tolerance and withdrawal to a substance, they are physically dependent. For example, someone who's prescribed morphine for the management of chronic non-malignant pain, they may over time become physiologically dependent on the opioid, stop the use of the opioid, they will develop classic withdrawal symptoms, generalized aching, abdominal cramps, diarrhea. They look like a plucked turkey, hence the term cold turkey. That is because they are physiologically dependent on the opioid. What DSM-4 does say is that there is a form of substance dependence which does not include evidence of physiological dependence. It would be much simpler if they referred to that as psychological dependence, but they don't. And this is part of the problem, because a lot of physicians will confuse substance dependence with physical dependence. They are not the same thing. So, to clarify it again, physical dependence. It's evident when a characteristic set of withdrawal symptoms develop upon discontinuation of the use of that substance. And if you question the patient more closely, you'll find that they have become tolerant. They're able to ingest more and more of the substance in comparison with what they did previously. And they need more of the substance in order to achieve the desired effect. Now, if they wanted simply to get a buzz, which they used to get from 2 or 3 drinks of alcohol, now they may need 5 or 6. That is tolerance. So tolerance and withdrawal is physical dependence. A far cry from psychological dependence, as defined here. That's a definition that I use. Won't find it in a book anywhere. I was always searching for a definition of what it is. But there it is. It's simple. It's the perceived need to use a substance in order to maximize your emotional potential. In other words, you've got to have a drink before you go out to a social event. You've got to have a drink before you face your boss. You can't relax after work without having had a drink. I couldn't come here and make this presentation without having a few drinks. That would be a case of psychological dependence. Until eventually you can't face the day without a drink or your use of a substance. And you can't, people therefore start drinking simply because the sun comes up and the sun goes down. They need their substance like healthy people need bread and water. That is psychological dependence. Completely different from physiological dependence. So in other words, if that patient is admitted to hospital for chronic non-malignant pain and some well-meaning physician says, oh, this person's on too much morphine, we'll cut them back. And then they go into withdrawal, and then they start to get belligerent and they want their morphine. They go up to the nursing station, and the nurse says, no, you're not ready for your dose. And then they start to get a little bit irritable. Then the nurse will respond by saying, yeah, that's evidence. You see, he's exhibiting addictive behavior. He's demanding his medication. But it's not. That is a case of someone just being in physiological withdrawal. It's not that they are necessarily addicted. Quite different. Is that all clear? So, if we were, for the most part, if we combine physiological dependence and psychological dependence, we come up with the term addiction. Again, it would be very much more helpful if the term addiction was included in DSM-4, but it's not. Why? Because remember back when it was published, 1993, the rise of political correctness. The term addiction was considered pejorative. It was unpalatable. It was demeaning. It was not politically correct to refer to a patient as being addicted. So the vote of the committee was just, I believe, by something like 11 to 10 to not use the word addiction. And what has it done? It's led to an unbelievable amount of confusion. Whereas if we now know that addiction is a disease, if we use that term and had it included in DSM-4, it'd be a lot simpler. But as long as you understand that, on the whole, physical and psychological dependence, for the most part, means that someone is addicted. And there are no 100% in medicine, but it's pretty darn close. However, as I just argued, physical dependence does not equate to addiction. All right? So what is addiction? Here's a definition. And that is really that put out by the Canadian Society of Addiction Medicine. It's quite a mouthful, isn't it? A biopsychosocio-spiritual disorder. Why is it that? Yes, because there's an overwhelming bank of genetic evidence to indicate that there's that basis for the development of substance use disorders. And the more genetic material you inherit, the greater the risk that your condition will progress to dependence. There are psychological factors, there are anthropological influences, there is cultural reasons, social reasons, nurturing. So many factors will go into the melting pot. And if all those factors are present in someone's development and their environment, it will tip the balance and that individual becomes addicted. And we know that if they do become addicted, they will express loss of control over the use of that substance. The use of the substance tends to escalate. And that's why patients who may start off being given one Percocet tablet for some back pain, 5 to 6 years down the road, are taking 800 milligrams of OxyContin daily. Those are the sorts of patients that we see at Clinic 528. We've got 2,000 patients on methadone in the city. And the majority of them are addicted or have been addicted to before they present to oxycodone, because there's just indiscriminate prescribing by too many physicians. I refer to addiction as being the 4-to-1 disease. Most students at Western spend 4 years in medical school. They get 2 years of teaching on the subject of addiction for the #1 cause of morbidity. I mean, really, addiction causes more harm to society than AIDS does. But yet, addiction is not really something pleasant, is it? It doesn't carry the interest. So it doesn't get talked about, it doesn't get funded, whereas HIV, AIDS does. But the two are really inextricably linked because so many people who are addicted suffer with HIV. So just as an aside, there's an escalating use of the substance, and that's why people can be on such massive doses of oxycodone by the time they present at Clinic 528. And invariably, their whole life is given up to obtaining the substance. For example, many people who are in the end stages of their addiction will get up when they wake up. The first thing they do is go in search of their drug. Once they've got their drug, they might eat. Then they'll probably sleep off the effects of the drug and repeat the whole event the next day. Their whole life is geared to that. And they will go to any desperate means to obtain it. So the consequences tend to get worse and worse. And it's associated with a preoccupation with obtaining and using that substance and recovering from the effects of the use of the substance. So that is a definition of addiction. Just as an aside, it's a spiritual disorder. Most people who are addicted are spiritually bankrupt. And what is spirituality? It has nothing to do with religiosity. In fact, I've got 3 or 4 members of the clergy in my practice. Devoutly religious people, but spiritually bankrupt. They had no connection with themselves, with other people, with society. They lived in their own world. The only relationship they have is with the bottle. But people who are in recovery can turn that all around. They become the most engaging, enlightening people who are at ease with themselves. They are content. You have to reach your own definition of what spirituality is. But as long as we're aware, it has nothing to do with being religious. So let's just compare what is the difference between addiction and physical dependence as I've just defined. I've hammered this point home that physical dependence is evidenced by the pharmacological phenomena of tolerance and withdrawal. I've gone over this enough times, so just want to emphasize that. However, addiction is manifested by the behaviors associated with substance abuse and substance dependence. In other words, the drug seeking, the organizing your life around obtaining the substance, the justification for using the substance, in other words, the addictive thinking that convinces you that you need to use the substance. How many people present in the emergency room with back pain? How many really have a physiological basis? The chances are that is a classic example of addiction. But no one's going to come into your department and say, "Doctor, I'm an addict and I need some morphine." It may happen occasionally, but not that often, because it's not acceptable to suffer from the disease of addiction. But it's all right to have backache. So subconsciously, the brain will sublimate the addiction into the expression of pain. So they'll come in holding their back and say, "I'm in pain." And they're more likely to walk out with a prescription. They're not willfully doing that, but that's the only way that they perceive that they can survive. All right? So physical dependence and addiction, quite clearly different things. There, let's compare them. So the purpose of someone who is physiologically dependent on, say, morphine is because they want to relieve their pain. But the addict, in actual fact, needs that substance because they're still trying to get that high. But as they become increasingly tolerant, it's much less likely they'll ever get high from using the opioid again. The dose escalates with the addict, whereas we know that some people with chronic non-malignant pain will remain on the same dose of an opioid for 10, 15 years. Doesn't need to go up. I have one patient in my practice who's on methadone for the management of pain, and I actually increased his dose of methadone from 60 milligrams a day to 65 for the first time in 4 years. Whereas if that person was addicted and not taking and was using the opioid for drug-seeking purposes in order to get euphoric, they would have been pushing for 400-500 milligrams of methadone by now. People who are taking opioids, for example, for management of pain will function pretty well, whereas the addict is invariably intoxicated because they're using more than they need and invariably taking other substances in addition. Right? So you can see that there's completely different presentations between people who are physically dependent, using, say, morphine for the management of pain, as opposed to people who are using morphine as a symptom of their addiction. All right? There is a condition that you need to know about is pseudo addiction, and I've really alluded to it already. That patient who gets admitted to hospital, some well-meaning physician decides to cut their dose of morphine in half because it's too high. And then the patient goes into withdrawal, or they experience pain. And I don't know if any of you have experienced chronic pain. It does get to you day after day. And if there's a fear that you're never going to be relieved of that, you start to become rather demanding. And it's difficult to differentiate those symptoms from the symptoms of drug seeking and addiction. But pseudo addiction is really best defined as poor pain management. And I believe that many doctors who keep on escalating the dose of a patient's pain medication are in actual fact thinking that they are dealing with poor pain management, but in actual fact they're really dealing with genuine addiction. And you need to be able to differentiate what is presentation of pain and whether you're dealing with someone who is addicted. And that really only just comes with experience. So to wrap this up, using the classifications that we're forced to use, i.e. DSM-4, and probably in 2 years' time, could be giving this talk again, talking about DSM-5, but don't expect any big changes. They're just not going to happen. You know how reactionary the medical community is, doesn't want to change things too much. But it would be much better if DSM-5 did include the word addiction and did make it much clearer what substance abuse is as compared with substance dependence. But for now, substance abuse, as defined in DSM-4, is present when the use of the substance interferes with the individual's life. It has negative consequences, it's hazardous, it's problematic. But the individual has never crossed the Rubicon. They've never exhibited loss of control. In other words, they've never become dependent. Right? That is substance abuse as in DSM-4. Clear? Now, let's just see what substance dependence is in DSM-4. To be substance dependent, as defined in DSM-4, you've got to have 3 out of a total 7 symptoms. You've got to exhibit tolerance to the substance, exhibit withdrawal, there's the loss of control again, inability to abstain, and you can see those two are pretty close. Narrowing of repertoire and preference for using is, again, pretty much the same, but preference really means that you're devoting more and more time to obtaining that substance. And narrowing of repertoire really means that you give up other interests. People who are addicted tend to give up their hobbies and their interests. They withdraw from the community. They stop going to church. They stop coaching the local teams. They eventually will sort of withdraw from their peripheral family. Then they start to sort of isolate from their own family. They spend time down in the basement. And then eventually they will start, they'll lose their job. And in the case of physicians, that is usually the last thing to go. Most physicians will believe that the most important thing they have is not their health, but their job. So that everything else will go. They'll give up everything else in order to be able to continue using the substance, but they'll need to continue their job in order to obtain the substance invariably. So that is narrowing of repertoire, and people will continue to use that substance despite repetitive negative consequences. So you have to have 3 out of those 7 symptoms. Now, this is the clincher. Why does it have to be 3? It's obvious, actually, if you think about it. If it was just 2, it could be those 2, couldn't it? If all you needed was 2 symptoms, and the patient came in and said they were tolerant and they would withdraw, but they didn't have any other symptoms, then that would not be appropriate, because that tolerance and withdrawal would mean that they are physically dependent. So, in other words, what DSM-4 is really saying is that substance dependence, as defined in DSM-4, is the same thing as addiction, because one symptom has to come from the behavioral cluster. All right. So, to wrap up, what we got clear here is that if you take all substance use disorders, and using that term broadly as in DSM-4, substance use disorders, that sometimes is used by lay people to mean substance abuse. So substance abuse, that term used by lay people, often is the same thing as what the medical community will refer to as substance use disorders. However, substance abuse is also a specific entity as defined in DSM-4. In DSM-4, we have not only substance abuse, we have substance dependence. And in DSM-4, substance dependence is the same thing as addiction. What is not talked about in DSM-4 is that other entity called substance misuse. Why? Because it is not really a medical entity. It hasn't caused recurring problems. So if you've got it clear, there's substance misuse, there's abuse, there's dependence. And substance dependence is the same thing as addiction. And bear in mind that there's that other entity called physiological dependence, which is something quite separate.